Welcome, dear audience. Let me present my PhD topic, which is the role of biomarkers in the individualized management of the critically ill. My name is Nikolett. I'm a specialist in anesthesia and critical care, and I work at the Semmelweis University Department of Intensive Care. My specific goals focus on urinary biomarkers, the first project, and in my second project I am focusing on a physiological biomarker, which is the central venous oxygen saturation. So my first project is about investigating the predictive value of urinary biomarkers in cardiac surgery-related acute kidney injury. Cardiac surgery-related acute kidney injury is a very common complication after cardiac surgery, and it increases mortality up to 60%. There is no specific treatment option available, so we need to focus on early recognition and preventive measures. We know that we use the KDIGO criteria for diagnosing acute kidney injury, but at that time, when we are able to see the increase in serum creatinine, the damage to the renal cells is already done. So we would need a predictive tool, which may be the urinary biomarkers, which are released as a signal of renal stress and early renal damage. Their moderate predictive value to predict AKI in several critical conditions is already known, but their performance regarding cardiac surgery-related acute kidney injury is unclear. So that's why we wanted to examine the urinary biomarkers if they are able to accurately predict the development of cardiac surgery-related acute kidney injury. We included papers with who included patients undergoing cardiac surgery, and our outcome of interest was development of cardiac surgery-related acute kidney injury based on the KDIGO criteria. We performed our systematic search in 3 databases. We ended up with 86 articles, from which we were able to include 79 articles reporting on 11 biomarkers in our quantitative analysis. In this first table, you can see the individual biomarker prediction of all stages of CS-AKI and severe CS-AKI at different measurement time points. The subgroup analyses were based on merged measurement time points. And you can see that the pooled AUC values reached the highest, which we found was 73%, which means that these individual biomarker measurements identify approximately 75% of acute kidney injury patients after cardiac surgery. We were able to pool data from the combination of biomarkers for prediction of severe cardiac surgery-related acute kidney injury, and we could see that their accuracy reaches the excellent level, 0.85, so they can be better used in prediction of cardiac surgery-related acute kidney injury. We were also able to pull data about clinical models used for this prediction, and also clinical models which also incorporated measurements of urinary biomarkers. They also have better predictive value, but the difference is not significant. So the strength of our study was that it's the most comprehensive study in evaluation of cardiac surgery-related acute kidney injury predictor urinary biomarkers, and its limitations is that there is a high risk of bias due to the inconsistent reporting of biomarker level measurements. As a conclusion, we can say that individual urinary biomarkers have acceptable accuracy in predicting cardiac surgery-related acute kidney injury, and a rather combination of urinary biomarkers should be used because they have excellent discrimination. And if we are only able to measure one biomarker at a time, then we should measure it intraoperatively or in the early postoperative phase. We have submitted this manuscript and is currently under review at the British Journal of Anesthesia. My second project, we focus on central venous oxygen saturation, and we would like to know whether it can help to individualize transfusion in the critically ill. It is a protocol or a planned protocol of a randomized trial. We know that 25% of ICU patients receive red blood cells, and international guidelines recommend a restrictive transfusion policy. These transfusion policies rely on hemoglobin levels, and these are the transfusion triggers, but there may be physiological transfusion triggers as well, which are not widely investigated, and no clear evidence is reported on these. Transfusion is used to maintain the adequate peripheral oxygenation in the critically ill, and the tissue oxygenation depends on the oxygen delivery and the consumption, and central venous saturation represents an imbalance or a balance between the supply and the demand. So oxygen delivery can be improved by red blood cell transfusion. That's why, as I said, there is no clear evidence on the physiological transfusion triggers, namely the central venous oxygen saturation. So our aim was to investigate the efficacy and safety of central venous saturation guided transfusion triggers versus the transfusion based on a clinician's decision in the critically ill. Our population will be adults on critical care unit with a hemoglobin level between 7 and 9. The intervention will be transfusion based on the central venous saturation. We will compare it to the standard care, which is according to the guidelines. It's a clinician's decision based on comorbidities and clinical signs. And we would like to know if we are able to reduce the number of red blood cells transfused, and if there is really a change of the central venous saturation after transfusion. And we are hoping that with less transfusion, we will achieve less organ dysfunction. So our eligibility criteria can be seen here. We would like to include those patients in the intensive care unit who are stable, I would say out of the woods, so already hemodynamically stable, non-bleeding. They are monitored with central arterial line, and they also have hourly urine output monitoring, and they also have a stable oxygenation. And after including them based on their hemoglobin level, they will be randomized into a control and the central venous saturation group. And if their saturation, the central venous saturation is below 70, then we will give blood to them and then reassess every 4 hours. We are interested in the total number of red blood cells transfused and the change in central venous saturation. And we also would like to know the length of vasopressor requirement, length of mechanical ventilation, so the safety outcomes. We are at the phase of the preparation of the protocol, and I have presented the results of my first study in these 2 congresses. Thank you very much for your attention. Have no fear of perfection, you will never reach it.
Congratulations, Nikki, for the nice presentation and research. I have 2 questions. First one is, what is your clinical practice in your institute regarding the biomarkers? So which biomarkers do you use? And the other question is that I suppose that the length of the surgery, the cardiac surgery, is a prognostic factor regarding kidney injury.
Yes.
Regarding the different biomarkers, are there differences in the sensitivity or the specificity of these biomarkers for the length of the surgery?
Okay.
Thanks.
Thank you for the questions. Your first question refers to the urinary biomarkers, I believe. Yes. Yeah. So currently, in my previous institution, where I worked as a cardiac anesthetist, we did not use any urinary biomarkers. So we just anticipated from the clinical signs that this patient might develop AKI, and then we verified it with the KDIGO criteria, so we didn't use any. And for the second part of your question, if the length of the operation is a prognostic factor for AKI, it may be. And also, so there are sequential measurements of these urinary biomarkers, so they are not measured at one point. Usually they are measured preoperatively, and also there is a great heterogeneity between the results, but there is usually one measurement intraoperatively, or even 2 or 3 measurements, and there are at certain exact time points, for example, after induction, which is a relatively fixed point, or when weaning off from the cardiopulmonary bypass, it is also a fixed point, or arriving at the intensive care unit. So there is a sequential measurement, and yeah, so that's how it's measured there.
Thank you very much.
Thanks.
Thank you for the great presentation. I have 2 questions for you. One is simple and the other is a bit more complicated. So the first one is, what is the mechanism of your first article? So what is the mechanism of this cardiac surgery-related acute kidney injury? Is it pre-renal or renal? Mm-hmm. That would be my first question. And the second one is more specific to radiology. In the post-operative phase, there may be a computed tomography needed for complication and to see what kind of complication can be detected. And in those cases, sometimes a contrast agent can be employed. And what is the is there a role for these biomarkers to judge if it is feasible to use contrast materials, iodinated contrast material, compared to creatinine, which is the reference test to judge if it's feasible to use contrast agents after surgery for elective and not in an indication that is for judge if it's I don't know the exact term, unfortunately, so to judge if it's a serious or not so serious one, so like an elective or an elective-like indication. So is there a difference?
Thank you for your questions. The first question is what is the mechanism of this cardiac surgery-related acute kidney injury? So it's absolutely multifactorial. There are patient factors, which are preoperative patient factors, for example, diabetes, already existing chronic kidney impairment. There are also operative factors. If the hemodynamic stability during the operation, the use of cardiopulmonary bypass during the operation, because of the cardiopulmonary bypass provides a continuous flow in contrast to the pulsatile flow, which we all have, and it tends to worsen the kidney function, so it's absolutely a risk factor. So if there is a long cardiopulmonary bypass time, it will aggravate the acute kidney injury. And there is also the inflammatory response because of the major surgery itself and also the cardiopulmonary bypass machine itself. So it's a silicone tubing, so there is a massive inflammation after these operations. So that's also intrinsically affects the kidneys. So yeah, so it's absolutely and yeah, I'm sorry. And there is one more: the amount of transfusion given during the surgery. So these are all contributing factors for developing an AKI. And for your second question, so the urinary biomarkers have been investigated for contrast-induced nephropathy or contrast-induced acute kidney injury, and they can be used for that. And they reliably, with the same specificity and sensitivity, like around 75% of sensitivity and specificity, they will tell you if that patient is going to develop contrast-induced AKI after your CT. Was there anything else?
And even earlier than serum creatinine. So serum creatinine can be normal, and these biomarkers can predict that there will be an acute kidney injury later on?
Yes.
Yes?
Yes, so you do the, so not the pre-procedural measurements of these urinary biomarkers, so then you have the creatinine. The pre-procedural biomarkers have no real use. But if you do the measurements of the urinary biomarkers like 2-3 hours after the CT, the contrast-induced CT, then you can see if there is a trend or there is a chance that it will, the patient will develop AKI, and then you can intervene with preventive measures, which we actually do in everyday practice without measuring the urinary biomarkers.
Okay, thank you very much. That was my question.
Thanks.
Maybe I will have again. So Nikolett, I think I didn't ask you previously during the progress report, how did you deal with cutoff values? Because this is just, I can imagine that among your studies, many cutoff values were used. So what was your strategy?
Yeah, so this was what we anticipated, that we will have humongous amounts of cutoff values, but it was not the case. We only had one biomarker where we had established cutoff values. This was the TIMP2 IGF-BP7, this is the nephro-check test. There they have established cutoff values which they used, so we could pool, we could do a sensitivity, so we could do a proper analysis, sensitivity and specificity, we could pool them, and we could also give a recommendation which cutoff value to use, where you have the higher specificity and sensitivity, and it was actually lower than the manufacturer suggested. And all the other biomarkers, we had scarce cutoff values, not with the same unit of measurements and not measured at the same time. We couldn't really pool them, and we couldn't really use them in any analysis. That was the decision of the team and mainly my statistician. Yeah.
Congratulations for your work, very interesting. But you already told us something about the inflammation. It's very important in producing kidney damage. So did you think to use also the inflammatory markers in this respect, not only urinary biomarkers?
We didn't use, or
interleukin,
we were not,
for instance.
So we didn't look into the inflammatory markers because after cardiac surgery, all inflammatory markers are just really high, and we cannot really draw too much conclusion. But there wasn't. There were many articles which didn't even report their inflammation.
I think the evolution, the dynamic of changement, because checking before surgery and being normal, for instance,
yes.
and the dynamic of their concentration.
So that dynamic was not measured. The urinary biomarkers were repeatedly measured.
I understood in the literature, but for your research?
After conducting this meta-analysis and looking through all the data, I did not think that we should research in our own data the same things. So we did not conduct our own research in our own patient population.
Congratulations again. And what I wanted to ask is that you spoke about cardiac surgery related to acute kidney injury. But as you very nicely stated, cardiac surgery is a very huge umbrella. So there are, on-pump, off-pump surgery, there's valve surgery, coronary surgery, acute surgery, chronic surgery. So were all these cardiac surgeries put together in your... And
Yes.
is that wise to do that? Because there are so different forms of cardiac surgery.
We thought of that initially, and we planned to do a subgroup analysis based on on-pump and off-pump surgery. It wasn't feasible because most of the studies deal with not they deal with heterogeneous population, and they also pool them together. So it was not possible to do it. But yeah, this idea was in our minds as well.
Okay. And another question that you looked for urinary biomarkers, but did you look for not inflammatory, but like NT-proBNP or troponin T as a measure of, cardiomyocyte injury or hemodynamic instability, because that might also predict acute kidney injury?
No. We only looked at renal biomarkers, so produced by the so only urinary biomarkers, which can be measured in the urine.
That would change a little bit your mind.
Yes, definitely.
From today, yeah.
You have had a lot of questions on your first paper, but nobody has asked on central venous hemoglobin oxygen saturation protocol. I'm interested in the cutoff of central venous hemoglobin oxygen saturation. Will you use the same for every patient, or you will be more flexible and to take into account of some other factors, hemoglobin concentration and so on, because for transfusion is not a yes or no point when we make a decision. There is a strong indication, a relative indication, a relative non-indication, and a certain non-indication. So anyway, this is a wide range of chances to start a transfusion. So it's already two questions. Will you use the same for every patient, or you change it day by day or hour by hour? I mean the cutoff point. So
thank you for your question. We planned to do a strict cutoff, which is going to be 70%, and rather control for the population of the included, so the inclusion criteria. So we also planned to exclude very severe heart failure patients, for example, because with the cardiac output part, it can also influence the DO2. And we also said that they can be, for example, ventilated patients, but they need to be in a stable phase and not in a so not in a worsening phase of the critical condition. Then we were also planning to set up a cutoff for the FiO2 and also the arterial saturation, so that we will be able to control for all the parts of the DO2 apart from the hemoglobin. So that was our idea, that somehow we need to make these patients homogeneous, or this population, so that we can apply a strict certain cutoff for all of them. But we are in the developing phase of this idea. But yeah, we may have to apply a flexible cutoff in case of central venous saturation.